District, and we have Todd Landry, the Director of OCFS, with us today. And I'd like to hand this over to him to say a few words before we start with the presentation. Todd?
Thank you very much. As Jessica indicated, I'm Todd Landry, and I serve as the Director of the Office of Child and Family Services within the Department of Health and Human Services. I'd like to start off by saying thank you for taking your time out of your very busy schedules in order to participate in today's public meeting on the topic of PRTF and rate setting. PRTFs, as we acronymize it, stands, of course, for the Psychiatric Residential Treatment Facilities. And the topic of PRTFs has been one that I know many of you have participated in discussions on here in the state of Maine, as well as for many of you, discussions across the country around the topic of PRTFs, where PRTFs fit in an overall continuum of care of children's behavioral health services, and how different states and certainly different strategies here in Maine for meeting those needs of youth who medically need that level of service. Today's meeting is a public opportunity for us to share with you some information around rate setting that we have done, as well as provide a little bit of history around what has gotten us to this point. I'm delighted to be here with a number of my colleagues here at OCFS, as well as our colleagues at the Office of Maine Care Services and others within the state. So my thanks to all of them who have worked diligently to get this project to this point. And again, I want to say thank you to all of you for taking the time out of your schedules in order to participate in this public meeting. So I think I'm going to turn it back over to Jessica. She's going to share with you a little bit about some of the housekeeping rules, so to speak, in order to make our time today as beneficial for everyone as possible. Thanks again for participating, and we look forward to hearing your comments.
Thank you, Todd. I'm going to ask Mandy while I'm talking to start to present the first slide on our presentation. So while that's coming to your screen, I'm going to go over a few housekeeping things, as Todd said. I want to remind everyone that we are recording this forum via Zoom. When the forum's complete, we will be saving the recorded event and provide a link in an e-message for you so you can access this. I'm also going to paste some instructions in the comment chat so that you can know how to raise your hand to make a comment. And we would like to have comments saved to the end of the presentation. At that time, we'll be calling on you in order that your hands are raised for a comment. In the interest of time, what we would love to have everybody do is introduce yourself into the chat. And I want to remind, even though it'll be in the chat instructions, that if you are from a telephone, in order to raise your hand, you have to press *9 in order to come through. So we're going to go ahead and start the presentation. Mandy, could I have the first slide, please? Thank you. Today, we're going to go over the following information. We're going to discuss rate determination process and the scope, background on the PRTFs themselves, the service model review process, and overview and details of this process, a proposed rate, the proposed rate and rate model, how we got to this, education considerations, and towards the end of the presentation, we will also discuss the timeline and public comments, how you can make them. Next slide, please, Mandy. The rate determination process is determined by the Public Law 2021, Chapter 639, which took effect in August of 2022. And this establishes the process for our rate determination now. So that includes things like stakeholder engagement and public presentations like what we're having today, so that people can review the draft model. You'll have an opportunity also so that people have an opportunity for written comments, and DHHS responds to the written comments, and following the rate determination process, OMS engages in a formal MAPA rulemaking, which includes additional opportunities for public comment. I just want to say for those on the call, for MAPA is abbreviation for Maine Administrative Procedure Act. So what's next for the PRTF services that we'll be doing today's meeting? Then we will explain to you how to submit any comments that have to come in to us by July 7th of this year. The department will review those comments and respond to comments. The department may make adjustments based on these comments to our rate model and or our methodology. So the comments are super important for your participation and for us to hear your feedback. The target date for the rulemaking is spring of 2024, following the map of rulemaking. Next slide. Okay, at this point, I'm going to turn this over to Jenny Patterson. Thank you.
Great. Thank you, Jess. Hi, everyone. My name is Jenny Patterson, and I am the Director of Policy for the Office of Maine Care Services. And because our rate determination process for Maine Care is such a new process, and because there are so many components to PRTFs, we thought it would be helpful to just give a little background information about what is the scope of the conversation that we're having today. And so you can see in pink that our rate determination, what we're presenting today, really is focused on two things. It's the rate model for the PRTF and how we are proposing to change that a little bit from what exists now. And then we're also looking at reimbursement for medically necessary one staff for PRTFs or special education behavior support services. There are other aspects that relate to PRTFs, including, as Jess mentioned, the formal rulemaking that will take place following this determination. So that will involve from my department updating Maine Care Benefits Manual Section 107 to add the new rates and new services. And then finally, there are aspects of PRTFs that are overseen by the Department of Education. So I want to say thank you to our DOE colleagues with whom we're having ongoing discussions, and I know some of them have joined today. They are involved with oversight of instruction that occurs within a PRTF, and then also to the degree that there are portions of the facility that are dedicated to education, that would be something overseen by the Department of Education. In addition, for some medically necessary services, those might be services that are listed on an IEP, and so that IEP would be overseen by the Department of Education. So next, I will turn it over to my colleague Dean Bugaj to present the next slide.
Thank you, Jenny, and good afternoon, everyone. I'm Dean Bugaj. I'm the Associate Director for Children's Behavioral Health Services with the Office of Child and Family Services. And if we can get on that next slide, I think we were there, but we just hopped back a moment. I just wanted to talk a little bit about just PRTF, what it is as a service, and then talk a little bit into some of the previous work that we had done to work on developing PRTF, and then some of the feedback that we've learned to then inform the model that we are talking about today. So just for high-level overview, PRTF is a non-hospital-based facility delivering inpatient psychiatric care to youth under the age of 21. They must be CMS certified and meet additional requirements under federal law. And so services within the PRTF, they do include active treatment, intensive psychiatric monitoring, rehabilitative therapies, and medical supervised 24/7. So if we want to go to the next slide. So PRTFs, Yep, there we go. So PRTFs, and where do they land in our delivery system? So as Director Landry noted, PRTFs is one piece of our delivery system, and we are hoping and really using this rate determination process to work to establish a PRTF, which will close a gap in our system of care to provide really intensive psychiatric treatment for youth who need that service. And just looking generally at our behavioral health system as a whole, as we kind of look at this table, we're moving around here. Can we get back on that triangle? Thank you. Starting at the bottom, that really is intended. Those are our community-based services and our community-based resources that are available broadly, within our communities. They're generally not the ones that are specifically OCFS funded, though we do support in a number of areas. And actually, I think we do fund childcare and things like that. But generally, this is really looking at, what are the services available, that have the broadest reach, and impact. And then as we go in and up the triangle, the services get more expensive as we go, kind of, signaling to the $ track on the right side of the triangle. And then as we go up that triangle, it also impacts the amount of youth served. And so as services get more and more intensive, they are targeted to less and less youth. And presumably our goal is that the majority of services or the majority of youth will be able to be supported in sort of the, the bottom of the rungs, though we do recognize that, we do need intensive services to be able to support children and families. And so, looking up, PRTF is really just right above, under the top level of that triangle there. So just under the hospital, inpatient level of care, secure youth detention facility. It is kind of sandwiched between our residential PNMI services, crisis stabilization units, kind of looking at right there is that, intensive, secure psychiatric facility. If we want to go on to the next slide. So PRTFs and who are they really intended for? And so again, just noting that it's for youth with high levels of behavioral health care needs, who meet the criteria for psychiatric residential treatment facility services. This could may include a number of different types of youth, including youth who are needing non-hospital psychiatric treatment, youth that are needing a step down from inpatient hospitalization, youth currently receiving or seeking treatment in an out-of-state PRTF, so looking to potentially open up a facility in-state in order to support transitioning, those youth that are placed in out-of-state PRTF back to Maine, and then also youth that may be in other settings but meet the medical necessity, criteria for the PRTF level of care. Next slide. So a little bit of the background on PRTF is OCFS and really the department. So DHHS, including our Office of Child and Family Services, Maine Care, licensing, and the Department of Education, audit, and Department of Corrections. So DHHS programs, and then also outside of DHHS offices, really worked collaboratively to establish a policy for PRTF back in October of 2018. Following that, the state held a number of informational sessions to talk about PRTF services. And following those sessions, a provider did submit a proposal to the department on working to develop. We did work with that provider for a number of months, so around 15 months or so, to work to establish a number or work through a number of different questions, thoughts, considerations toward potentially developing a facility in Maine. Ultimately, we were not able to come to an agreement, and so that did not culminate in the creation of a PRTF, which then drove some other conversations. So we met with a few different providers to discuss their interest, but ultimately, the providers concluded that the rate was not sustainable for PRTF services, which, in part has led us to the conversation that we are having today. And so if we want to go to the next slide, we'll talk a little bit about some of the work that we've been doing over the past, couple of years. And so COVID notwithstanding, which definitely had an impact on our ability to really focus our attention on this specific work, we really work toward trying to seek and gain understanding both from providers in state in terms of what are the barriers to within current policy, specifically that could impact a willingness or ability to be able to open a PRTF, but then also meeting with other partners across the country to be able to learn around what are their PRTF models. What does that look like for successful implementation? What is their feedback in terms of our model as it was currently designed? And so really, as we did that, we did an informal RFI to get information, of which 12 providers were able to respond to that. And we're very appreciative of all the feedback that we got from that process. And then we also met with 3 specific PRTF out-of-state providers that have, national programs, so we could learn a little bit, directly from them. And so some of the feedback that we got is listed out on this slide here, really talking about, the original design that, Maine had in terms of really conceptualizing a 20-bed model was not really aligned with what programs were doing nationally, which are often, made up of 8-bed units. And so these 8-bed units are, typically within certain age ranges, considering gender, considering certain diagnostic needs. And so the general feeling was that, our conceptualization and what we built the rate upon previously around a 20-bed model was not really aligned and would create a barrier to trying to develop a PRTF. Secondly, our staffing ratio. So that's really for direct care staffing ratio. We had considered this as a very intensive level of care and thought that having an intensive level of staff would be necessary to be able to support and also prevent the need for one-to-one upstaffing. But when working through that, that creates a potential for a burden on providers to be able to have all of those staff available, and then it may not actually be conducive to creating a therapeutic environment to have all of those staff available at all times. And so a ratio of 1 to 2 was just given as feedback as being too high. Some other pieces, the salary cap for administrator was too low for a facility of this type. Certain administrative FTEs may remain the same regardless of the facility size. And so there was some concern around the inclusive of the in the medical rate, for some of those positions. Nursing, we had an initial ratio thinking of 1 to 10, again, based off of that 20-bed facility idea, and that's just too high and rigorous, for a facility of this type. And then really providers also noted a number of other challenges around strict requirements around physician ordering for restraint, seclusion, and whatnot. But to note here is that we are really unable to change those pieces because federal law is pretty prescriptive on what is necessary and required under the PRTFs. And so if we want to go to the next section here, we could talk a little bit about our model and some of the thoughts that we have. So next slide, please. So looking at the overview of our proposed model, what we are thinking about is taking that feedback from our national partners and really looking to design a facility based off of 8-bed units. And so when we look at that, we are considering that a minimum facility size could be 16 beds, and that a potential maximum facility size would be 48. 48 is really a number that we came up with based off of our own understanding of our census and potential need within the state of Maine. And so really kind of thinking that any one facility might cap out at 48 beds for a sustainable model. And so when we have built this rate assumption or rate model, it is on the assumption based off of that minimum facility size of 16 beds. And the idea is that it could be scalable from there. Next slide, please. So some of the pieces within our staffing model and some of the changes that we have made was really to make some shifts. So looking at that initial 1 to 2, we've looked at, sort of the, national models, and, there is a range between 1 to 4, 1 to 6, maybe enough to 1 to 8. We've landed on 1 to 4, thinking that that would be sufficient for a facility, of a 16-bed, size as we're kind of building the rate model off of. So 1 to 4 for awake, 1 to 8 for overnight. And then we also are recognizing that there may be need for additional one-to-ones to support whether it is during the school day for educational reasons under IDEA or separate to support in the PRTF generally, so non-education, non-school day related. And so we are looking at being able to have a rate to support that upstaffing as well. Nursing would be shifting from the 1 to 10 to 1 to 16, again, to kind of, the theme kind of around that 16 beds is that a nurse would be available for that 16-bed facility, and that there would be nursing support through a CNAM to support with that as well. And CNAM is we feel it's necessary versus another type of credential like a BHP with a CRMA certification, particularly because of supervision and oversight rules under licensing. So a nurse cannot, through their license, oversee a CRMA, a BHP with the CRMA, but they can oversee the CNAM. And given that there's similar medical roles for that from a supervision standpoint, working within scope, that seems to make a lot of sense. Clinician staffing ratio, we had a 1 to 5, and so we've adjusted that to 1 to 6. And then we've also looked at the medical director and clinical director needs for the facility, and thinking that originally there was an expectation that there would be full-time for a facility of any size, and so we are recognizing that that might potentially be a little bit of overkill, though we're certainly looking for any feedback from you all during this process on that model and the assumption. But we're thinking that it could be appropriate for a third of an FTE for a medical director per 16 beds to be able to fulfill their duties and the oversight and support through treatment, care planning, and any medication needs, things like that. And then a clinical director, providing oversight of all the clinicians at the 1 to 6 clinical programming, could be a half FTE for 16 beds. We've also created 2 new positions, and this is partially based on some of the feedback that we had received working through our provider, and that we did not consider any type of shift supervisor role within the original rate model. And so we, as those are pretty common and necessary across residential facilities, we wanted to build that in. and thought it would be appropriate to have a 1 to 16 ratio for a shift supervisor, and be able to support during the kind of wake hours during the day for that. And then we also created a crisis services provider or position as well, to be able to support with education, training, and support in any of those, crisis, issues. So, supporting with de-escalation training, and then any potential intervention. So, let's see. And then just, lastly noting, I already made a note to this, but, around the, ordering for restraint procedures, we are unable to change those, and those are governed by federal law under 42 CFR 43 subpart G. And so they are pretty prescriptive, for that. So next slide, please. And I believe I'm going to pass this back over to Jenny Patterson.
Great. Thank you, Dean. Hello again. I'm Jenny Patterson. I'm the OMS Director of Policy. And again, just to be clear on kind of the scope of what this rate model includes and how it relates to educational considerations, as Dean just explained, the proposed model would maintain consistent 1 to 4 BHP staffing during the school day. However, if there was a student with an IEP who needed additional behavior supports, basically the approval process and payment model for such supports would mirror the process for school health-related day services. So there would be prior authorization, and there would be seed funding for that IDA service. And then third point is that Medicaid programs cannot cover academic instruction. And so capital costs that are related to general education would not be included in the rate model. So next slide, I think it's Peter Kraut.
Nope, this one's still Dean.
So I think we need to go 1 slide further.
Okay, this one is me. I'm Peter Kraut. I am MaineCare's rate setting manager. So on the next slide, we will put up the rate model that led to the rate that we are proposing today, namely $606.83 per diem, which is a 25% increase above the rate that is currently in the MaineCare Benefits Manual associated with the 20-bed model that Dean had referenced. Also, we recognize that there are some members who will need one-on-one staffing that might be related to an IEP, or it might just be medically necessary having nothing to do with an IEP. And for that upstaffing, that would be reimbursed separately from the general per diem. And in the event that a youth needed that upstaffing, it would be reimbursed at $39.68 an hour. And on the next slide, you'll see where that comes from. Importantly, in that first bullet, the 606.83 is the direct care rate. So it is tied specifically to the to the staff that is interfacing with the members, and also the salaries of 3 other individuals that don't necessarily have direct face time with the members, namely the administrator, the medical director, and the clinical director. So it's really staff costs that are built into the direct care rate. The third bullet on there, fixed and routine costs, would be cost settled outside of that direct care rate. So that's the cost of the facility. It's, it's the capital costs or the rent on the building. It's the utilities. It's the billing staff. It's snow removal. All of that stuff that is really separate from the patient care. And of course, those costs can really vary considerably from one part of the state to the other, and also depending on the size of the facility. And that's one of the reasons that would be reimbursed in a separate rate. Next slide, please. Okay, so what we see here is the rate model that led to that 606.83. And I'll just briefly walk everybody through it. You can see that we've grouped sort of across the top under the 7 days per week. those are the direct care staff. And so all of the positions listed are the ones that Dean had gone through in terms of, here's the revised model. We've changed who the workers are, and we've changed what the ratios are. In the 5 days per week, there are those other 3 positions, the administrator, medical director, and clinical director, whose costs are built into this rate. And for those, the ratio, the first 3 rows basically show what the number of members per 1 staff ratio is for each of the 3 shifts in a 24-hour day. So just really simply, you can see that for most of the 7-day per week direct care workers, we're talking about 16 youth per 1 staff, really 24/7, with the exception of the shift supervisor who isn't there during sleeping hours. The 2 exceptions to the 16-to-1 ratio is number 1, the actual clinician, the LCSWs or LCPCs or LMFTs, where basically they would only be there during waking hours. And basically we're talking about 6 youth for every 1 clinician. So basically that's the caseload. Each clinician has a caseload, well, in the course of a day would be assumed to be seeing 6 members. Then you have your BHPs over on the left, where we have the higher ratio of during waking hours. It would be 4 youth for every 1 BHP. And then at night, it would be 8 youth for every 1 BHP. And we don't have ratios like that for the administrator, medical director, and clinical director, because those aren't really member facing. So you don't really need to worry so much about a ratio. But in the next rows that you see, hours per day and FTE per day, it's just 2 different ways of conveying the same information about, in a given day, looking at FTE per day, you're going to have 10, basically 10 BHPs, 2 shift supervisors, 3 crisis workers, 3 RNs, 3 CNMA, and then 2.67 LCSWs. I mean, LCSW, it's not really a direct patient ratio, but it is scalable more so than those other positions. Those other positions, like if you were to add a 17th youth to the facility, or a 17th bed, you would sort of need to hire another BHP in order to maintain your staffing ratio. Whereas it's a little more fluid with the LCSWs, where you just want to make sure it's not as much about patient safety as it is about the caseload for each clinician. Lastly, you can see that basically what we're assuming, and everything on here is per 16 bed. So when we set this rate, it is for using an assumption of a 16 bed facility. And so it is perfectly scalable, but really in increments of 16. And so what we're doing is we're dividing the costs that are associated with all these staff by 16 beds, and then saying that's the cost per day. Now, if a provider were to go to a 17th or an 18th bed, they could, but the rate would no longer work. It's really most efficient when the rate works best when it's a multiple of 16. And so what we're saying is, if you're a 16-bed unit, you would need 1/3 of an FTE for an administrator. You would need 1/3 of an FTE for a medical director. You would need 1/2 of an FTE for a clinical director. But if you were a 32-bed instead of a 16-bed, the funding generated by this rate would be sufficient for you to have 2/3 of an FTE for administrator, medical director, and so on. In the next row, you basically see what our assumption is about the hourly wage. This is taken directly from the Bureau, the Federal Bureau of Labor Statistics, and it's data that is specific to Maine. The BLS, Bureau of Labor Statistics, they do these surveys every year in all 50 states. And so we have used the median wage from the most recent data that is currently available, which is from May of 2022. And then we have inflated it to basically next July, because the rule won't go into effect until next year. And we always use sort of we use the wages inflated to the midpoint of those of the year into which it goes effect. If we use the 2022 wages, the rates would be inadequate by the time that this rule goes into effect, which is why they are inflated. And then below that, just for people who think in annual salary terms, instead of, hourly wage terms, you can see that what that would be as an annualized salary. And so, for instance, Dean had put up on a previous slide that we had gotten comments that the current rules cap on administrative salary, which was $80,000 in the current rule. Here, we're building in an assumption that, the necessary salary for a full-time administrator would be $112,000 next year. So there you can see sort of what we are assuming for the salaries and wages of those various positions. The next rows basically gross it up for the cost of benefits. And there are all sorts of assumptions in terms of, what does a health insurance policy cost? What is the take-up rate going to be? And these are percentages that Burns and Associates, a vendor that does rate studies for us, calculates each year based on the most current data. And so basically in the hourly staff cost with wages and benefits, we have grossed up what you see a couple of rows above to include the cost of these benefits. And included in that gross up is the cost of payroll taxes, such as Social Security and Medicare. Close to lastly, the row called productivity adjustment. Basically, the footnote there, the purpose of a productivity adjustment accounts for the fact that of every 40 hours worked, only 33 and a half hours is actually member facing. And that's because of things like, PTO, and to a lesser extent, time spent in trainings, time spent just fulfilling the requirements of being employed there. But because of those, even though the organization is paying for 40 hours, a 40-hour work week, not all of that is spent with the members fulfilling the ratio requirements. And so it's a way of grossing up the hourly cost to account for the fact that you actually need 40 hours of time, really available to be member facing. And so basically, the hourly staff cost, wages, and benefits gets grossed up, you can see, in order to achieve that. There is no productivity adjustment for the administrator, medical director, and clinical director, again, because they are not, client facing. Lastly, we calculate the cost per day by multiplying that staff member cost. So BHPs, for example, we multiply the $39.68 cost per hour times 80 hours per day. We get that 3,174, and we just do that for all the rows. In the next row, we add it all up, basically comes to $62,000 per day in staff expenses. Divide that by 16 beds and 7 days, and you get your cost per bed day of $558. And then, we recognize that you're going to have periods when you have empty beds. So that if we were, dividing those costs under an assumption that all of your beds are filled 365 days a year, but then they aren't filled all 365 days per year, we'd be dividing by too high a number, and the rate would be too low, since it is a reality that you have empty beds sometime. And so, consistent with the 92% occupancy that we used in our PMI-D calculations a couple of years ago, we're using 92% occupancy, which grosses that rate up from $558 up to $606.83. And so that's where that number has come from. I know that was a lot of information. And when we open it up for questions, people should feel free and to comment or question. And I'll also note that we will be posting this information at our website so that folks will be able to see it and provide any comments on any of the specific numbers. Next slide. And back to Jess.
Thank you. So we're getting there. So our current timeline is on this slide. So we would like your public comments on the rate model to us by July 7th. And my email is right there on the slide. It's also going to be on the e-message that you should be on the lookout for. So if you don't capture it here, don't worry. There's going to be an e-message that goes out with my email address as the contact. So that's an important date to remember, July 7th, to get your comments into us. And then as far as the MAPA rulemaking, we are on track to propose the rule by fall of 2023, and then the rule adoption would be spring of 2024. At this point is what we've all been waiting for, is the time for questions and comments. I did paste in the chat how to raise your hand for comments. And what we will do is we'll call on people as their hands are raised. We ask that you would, when you unmute yourself, that you state your first and last name, title, and the organization you represent. And we will let the questions begin. If you're on your phone, just one more thing. To unmute, you're going to have to do *6 on your keypad. Okay, Caroline, looks like you're first.
Hi there, I'm Caroline Raymond. I'm the Senior Director of Community Services for Maine Health. Thank you, Jessica. Peter, I appreciate this overview and had a question about the gross salary. Is that taking into consideration the backfill that you have to do for those staff that are out on vacation?
Yes.
Okay, thank you.
That's part of the productivity adjustment.
Thank you.
You're welcome.
If you have any questions, don't be shy. We're here to answer. Oh, Caroline, go ahead.
I don't know if this is the right time to ask this question, but just in terms of the design, I know that the maximum age is 21, but is there a minimum age for those clients?
That's an excellent question. In the benefit, there's not a minimum age, though I think, for any youth to enter a facility of this type, there is a clinical certification of need process that is very scripted and certainly intensive. And so there would be very careful consideration for any youth entering this facility, but I would think certainly for any that are younger.
And Dean, will there be any restrictions around the maximum spread in age between youth?
That is something that I think is really for licensing, but I believe it is common for facilities to, have the 8-bed units that are on a spread of, a certain age range to prevent younger youth being, co-housed with older youth. So certainly there's consideration there.
Thank you.
Okay, thank you. Christy, go ahead.
Hi, I'm Christy Worcester. I'm the Chief Program Officer at Sweetser. And I am just curious, most of our residential programs at this point have on-call, either on-call nursing or on-call psychiatry providers, or even a licensed clinical social worker that's a supervisor. And it's really necessary with 24-hour. And I see, although there's a crisis worker here with things like the federal law with restraints, was on-call pay incorporated into this rate?
I cannot, there we go. I was trying to unmute. We don't have an explicit line for on-call pay. Mandy, could you just go back 2 slides to the rate model? I just want to, let's just look at how all the shifts are staffed. Shifts? Yeah, shifts are staffed. So shift supervisor and Dean, I'll look to you too. So let's see. So we've got, yeah, the crisis worker is, let's see. So the LCSW, so we've got the RNs there 24/7. We've got the CNMA ends there 24/7. We've got the crisis worker there 24/7. Yeah, I mean, this will be a program design question that we can take back.
Thank you.
Yeah, and if you want to provide written comment, yeah, I mean, and we're really looking for comment, obviously not just on the rate, but on the model. And so, you know, if you think, you know, something is too thin or something is too heavy, you know, let us know.
Thank you so much.
Yeah, I think just on the model, you know, certainly understanding, you know, the CMS requirements specifically on ordering restraint seclusion, you know, we did feel it necessary to have a nurse available 24 hours a day in order to be able to support with that, and to be able to, you know, potentially make calls to the medical director, or, you know, potentially, you know, supporting physician, depending on how a facility would want to organize and spread that work. You know, but I think, you know, generally, and Peter, this could be a question, you know, from a rate setting perspective as well, but I think we were generally feeling that a third of an FTE would be enough for a medical director to, you know, support across their various duties, including, you know, that kind of on-call need. But if that's something that you would like us to, you know, consider a little bit more, we're happy to receive your comment on that.
Yeah, and it's sort of just to build on that, and you know, and so from the perspective of a large organization like Sweetser, you know, if you were to open up a 16-bed, for instance, you know, there's that question of, you know, we're assuming that a third of an FTE is appropriate, you know, and so it might be, you know, someone who's semi-retired, who's comfortable working that much or that little, or it could be, you know, you have somebody else on staff who's serving multiple programs. And, you know, we built in an assumption of $307,000 in salary, you know, when annualized, which we think is, you know, it's adequate and it's based on the data. And so it, you know, sort of would come down to the organization's contracting and setting the expectations of, hey, you know, we're expecting you to be on site, you know, a third of the time, but it is our expectation that you are also on call. And that would preclude main care needing to build special on-call dollars into it. But yeah, we would be interested to hear any thoughts that anybody has.
Okay, thank you. Lee, you're next. Thank you.
Hi, Lee DiTilio. I am a Senior Director of Intensive Services for Maine Health. Many of you may have been part of the 2018 conversations. I know I was there as well as a role of Spring Harbor Hospital. And one of the populations we talked about was the intellectual disability or autistic population. And I didn't hear any conversation about whether or not that population would be considered for this service, or if there would be something, a treatment that would be separate from here. Last time we spoke about this, I think there was some discussion about possibly older teens, maybe who were diagnosed with IBD, but just wondering if that was a consideration. And then I have another question, which is about length of stay, which is always something that I'm curious if there was something, if there was any consideration. The last time, I think there was some discussion about short term, like 90 days. So just wondering if folks have any information about that.
Yeah, thanks, Lee, for your question on you know, specific IDD, you know, youth. And so, you know, in the development of the you know, program in the rate model is that you know, really we're focused on, and as we kind of talked about, youth that are, you know, generally determined to be, medically necessary for this level of care, that can include a whole range of diagnoses. We didn't get into, splitting apart which diagnoses are appropriate, which aren't, but, certainly we have been, even I think historically, supportive of youth, with, a wide range of diagnoses to be able to get this service inclusive of, autism spectrum disorders and IDD.
And so to build on that, before we go to the length of stay question, I mean, if folks in reviewing this service model think, oh, this is sort of right in the middle, like maybe it's a little bit too heavy for behavioral, but it's too thin for IDD. I mean, if folks have comments and thoughts on, those two populations would require different staffing levels, it would therefore necessitate different rates. But again, the assumption is always going to be those 8-bed units. And, and any organization considering this, I mean, when you staff, if you have two different staffing models, that unit, I would think, would pretty much have to be permanently dedicated to that population. Otherwise, you've hired more staff than you need, or you've hired less staff than you need. And so, there would just need to be thought about, the size of what, so theoretically you could have a 16-bed facility with 8-bed, one of the 8-bed units is for IDD and the other 8-bed unit is for BHH, and they're going to have separate staff that can't really be shared. And of course, because if you look at this model, a lot of the ratios are 1:16. That is sort of based on the assumption, well, it is based on the assumption that two 8-bed units are going to be sharing staff. I mean, they're separate sides of the building. But by definition, if you have an 8-bed unit and 1:16 ratios, those staff are serving both units. So things could get a bit more complicated if we do it that way. Doesn't mean we can't. But so we will be interested to hear folks' comments. And then Lee, more specific to the length of stay issue, is the question about whether the rules are going to limit a length of stay? Or, I mean, it's not really tied to rates, right? The length of stay issue?
Yeah, correct. It's not necessarily tied to the rate. When we spoke back in 2018, there was a discussion about being short-term and only 90 days. And so I was just curious if there was some discussion about length of stay for this, for youth who may be at this program. So that was really just a question in regards to treatment, and I'm imagining families will be involved if they're involved, if the patients, residents have them and so forth, but just wondered if there were thoughts about the length of stay.
And again, as Peter mentioned, this is something that may relate to the rulemaking, but it's still really helpful to have the input, because when we get through with the rate determination, OMS will propose the rule. There'll be additional opportunity for public comment, but if there are things that we can think about, receiving those comments are helpful as well.
Okay. We're going to move on to the next question. Danielle.
Hi, I'm Danielle Loring, the Director of Intensive Services for ED Crisis at Maine Health. My question pertains to whether or not there's been any discussion or methodology established for how the youth would access this level of care, and if it would follow a similar progression that the current CRCF process follows, and if there would be a reform to that process as a result of this established level of care.
Thanks for the question, Danielle. There is a different process. It is a clinical certification of need, and there is criteria that is already built out into the existing PRTF policy, section 107, that kind of outlines what that looks like, who the team that needs to be involved. So I guess for that question, I would direct you back to policy to see what's required for the certification of need process, and that is something that is required federally to have that process with specific individuals involved, and it's typically a process that's done outside of the PRTF. And so we have been, at least previously in 2018, we thought about how we might be able to meet that requirement, and through being able to leverage our partners at, which I think is now Accentria Health, who was formerly KeyPro as of like a week ago, I think, to be able to kind of help meet that need, but it would be a different process than what is currently prescribed through our PNMI services.
All set? I did have a follow-up question from Lee in the chat. I just want to clarify if it was answered. Would BCBA be a billable service?
And I guess I'll just add, I have to step off in a moment, but I think my question is, if you are looking at folks who are on the spectrum, there are certain services that are beneficial to their treatment, and a BCBA, is a specific certification, and so that would be something you would want to consider if you do have that population. So that's the only reason why I ask it, and I am sorry, but I do have to step off. So thank you for the time today.
Thanks for participating, Lee.
Thank you, Lee.
Yeah, and thank you for the question. I mean, just regarding BCBAs, and I think maybe this is something that we can take back and think about from the department perspective, because I think there's, ideas and plans in the works, for those that have participated in the previous rate determination process for the behavioral health rate study with Burns and Associates. There was a BCBA, an independent BCBA rate that was established, and through that process, and perhaps that would be the most appropriate mechanism to involve BCBAs, through the service. But I think that's something that, certainly submit your thoughts and questions, and we can consider that from the department aspect.
Thanks, Dean. We do have a question in the chat that I'm going to say goes to Peter, asking about additional information about a room and board rate.
Yes, that's correct, Sean. And room and board would be part of the cost settled component of the rate.
Okay. There's nothing else in the chat at this time. No hands raised. We want to give everybody an opportunity to ask any questions before we leave the meeting.
And I guess before I forget, since this slide is up. So the previous slide had noted that, upstaffing of one-on-one for an additional BHP would be reimbursed at $39.68 per hour. On the next slide, the slide we were just at, I'll just show you exactly where that comes from. It's basically, if you look in the BHP column, it is the staff cost per member facing hour. And so basically, it's to be entirely consistent within our proposal. That's what we had calculated the cost of a BHP hour to be, inclusive of benefits. And so, yes, if there was an additional BHP needed, because there's a youth that needs one-on-one, consistent with the model, we would be reimbursing it at $39.68. And so that's where that number comes from.
Okay, I'm not seeing any additional hands raised or questions in the chat. Before everybody leaves, I just want to remind you to be looking for that e-message that's going to give you the links to today's presentation and also the PowerPoint, and it will also give you my email address so you can submit your comments. And again, the comments are due by July 7th so that we can respond to those. If no more questions, I'm going to give everybody back some time in their day, and we really appreciate your participation. Thank you.
Bye.